So you give me the. So you give me the start signal, do you?
Yeah. We will see. We'll have some speech because today's is the first program. So we'll have some speech only for 3 to 4 minutes. Then you will start your speech, okay?
Dr. Mangsho, কেমন আছেন? ভালো? How are you?
I think another speaker is also there, Dr. Raihan Rabbani. He is also there. Yes. Yeah.
Thank you.
So both the speakers are there.
How many participants registered?
It's about 173, but they joined only 26. But we have given message, but it will slowly they will sequentially.
173.
Yes, 173 has been registered. Maybe Orunangshu
Day e-learning master course on application of chemo port in cancer patient. We are glad that Alo Bhubon Trust and Beacon Pharma jointly organized this 3 days long master course program and opened the e-learning platform for many interested participants. Alo Bhubon Trust is a non-profit, charitable and voluntary welfare association. South Asia Center for Medical Physics and Cancer Research is a prime project under Alo Bhubon Trust, aiming to arrange meetings, seminars, workshops, hands-on training, awareness program with the national and international experts for the mass people, as well as relevant personnel of the different fields in health sectors. Beacon Pharmaceuticals Ltd is the leading oncology drug manufacturing company in Bangladesh. Beacon manufactures more than 75 generic products, which include the most sophisticated chemotherapy, monoclonal antibodies, and immunotherapies. Before going to the main session, I request the organizer to say a few words about today's program. On behalf of Alo Bhubon Trust, I request Dr. Ghulam Abu Zakaria sir, founder of the South Asia Center for Medical Physics and Cancer Research, to deliver his message. Professor Zakaria sir has been working in medical physics education and training in Germany for more than 40 years, as well as in South Asia, especially in Bangladesh, since 1990. Sir, please, you are requested to deliver your message.
Thank you, madam, for introducing me in this great audience. I will talk a little bit about our center. Just put Alo Bhubon Trust. It is a non-portable center, and we have a project. It is SCMPCR, and this project is actually a training center for all personnel associated with cancer. Yeah, it is the medical doctors. It can be radio oncologist. It can be radio diagnostic, and of course medical physicist, technician, and nurses. So we regularly organize seminars and workshop, hand-on workshop, and these all programs are accredited program. Yes, just now we have a Corona time, and so we have organized some e-learning course, and this e-learning course is a very good course, and 1 week course, and this course is specialized from experts all over the world, and it is accredited, and this course is with the examination. When you have examination, you have certificates, and you will get some credit points. And this is actually our activities. And we are happy that we can organize such types of seminar with the industry like you, the Beacon. Yes, we will work together for the cancer. This is a private organization, so it is not possible for this organization to do use for the area of South Asia, but the government should come forward, and the government is doing good work, and we will want to work as a partner. So this is actually our activities, and I will close this my small message, and thanks my groups, they organize it, and of course the Beacon for allow us for talking before the respected medical doctors all over South Asia, I think also outside South Asia. Last, I wish you a happy and peaceful and COVID-free healthy time. Thank you.
Thank you so much, sir. Now, on behalf of Beacon Pharma, I request our Senior Vice President, Dr. Mahbubur Rahman, Senior Vice President Sales, to deliver his welcome message on behalf of Beacon Pharmaceuticals Ltd. Sir, can you hear us?
He is muted, Nashita. Okay. Please unmute Mr. Mahbub.
Sir, you are muted. Kindly unmute yourself.
হ্যালো হ্যালো নাশিতা, আমাকে শোনা যাচ্ছে? Sorry, thank you very much for the actually I'm inside my vehicle and so anyway, this is a very big occasion for which we all are gathered here today virtually. This is very important for the context of Bangladesh because very few people know this technology of giving chemotherapy in the proper way, because cytotoxic agents are no longer used in any country of the world, especially in developed country, through the way it is used in Bangladesh. This is very, very dangerous because any extravasation leads to very dire consequences like sloughing out of skin and so many things. So although we are manufacturer of chemotherapeutic and other agents, but still we think we are part of this healthcare giving system where we all drive for excellence, where we all drive for development. And after this training session, I think the chemoport facility will be offered for more patients and more patients, although it's a bit expensive process, but I believe more patients will be using this method and will be benefited from safe administration of chemotherapy. So we are very happy to be a part of this, and we earnestly request the maximum presentation of doctors in this session. So on behalf of Beacon Pharmaceuticals Ltd, I welcome you all to participate in this session. And Dr. Rabbani, he is a very skilled professional in his area, because we hear his name for many occasions, especially in the arena of COVID-19, because lots of patients being admitted in his hospital. So we also thank him for his participation. Thank you very much all.
Thank you so much, sir. In this 3 days master course and first day speaker, we have with us Dr. Robert Semrau. He is a radiation therapy specialist since 2017. He works as a senior consultant in radiation oncology at Radiotherapy Bonn-Rhein-Sieg, Germany. Our second speaker is Dr. Raihan Rabbani. He is a consultant of intensive care unit and internal medicine of Square Hospital, Dhaka, Bangladesh. Now, without the further delay, we will turn the time over to our first presenter, Dr. Robert Semrau to present today's first topic, combination of chemotherapy and radiotherapy, enlarging the curative potential. I request to open the presentation for Dr. Robert Semrau. Thank you.
Please unmute, Robert Semrau. Please unmute.
Yeah.
So
it's-
now you can hear me, I guess.
Yes, it's okay. Okay.
I'm very sorry about that.
Yeah.
So let me introduce my name first. Thank you very much for being able to talk to you. My name is Robert Semrau. I'm a radiation oncologist. And I want to talk to you about the combination of radiotherapy and chemotherapy. You will now you will learn a little bit about the enhancing efficiency of these two modalities, because we are used to use these modalities, chemotherapy and radiotherapy, together to enhance the efficiency of tumor therapy. This is my agenda. At first, I want to talk a little bit about the mechanisms and the rationale of combining modalities. That means why we are using radiotherapy, chemotherapy together, and what is the reason for it. And then in the part, I want to give you an overview of certain clinical topics we use radiotherapy and chemotherapy together during the patient. First, rationale and mechanisms. It's not so new to combine radiotherapy and chemotherapy. There has been intense studying for years, and most of the data I will present to you today is from the 1990s or the beginning of the millennium, so the data is older than expected. But nevertheless, because of this data, we have powerful tools to treat the patients now. That means everything I show you is used in clinical practice, also in Germany, in every radiation oncology department and oncology department. Basically, there are three mechanisms which you can imagine combining radiotherapy and chemotherapy. The first thing is, then you want to treat metastasis and primary tumor at a different anatomical site. This means you need chemotherapy and radiotherapy for a kind of spatial cooperation. That means, for instance, the situations which you have in treating breast cancer. So we want to use radiotherapy to kill remaining breast cancer cells in the breast after breast conserving surgery, but also we want to use chemotherapy to kill tumor cells in the whole body. That means to treat the microscopic disease. So you need chemotherapy and radiotherapy at a different anatomical site, but the treatment is really built to be sequential. That means you don't want to have chemotherapy and radiotherapy given concomitantly at the same time, because this enlarges toxicity. The next is you want, in the middle, you see there is a possibility to have an enlarged cell kill possibility when you want to treat tumor cells at the identical anatomic site. You want to have an increased cell kill, for instance, when you treat Hodgkin's disease, because there you need chemotherapy to treat Hodgkin's disease, and you use radiotherapy to treat the remaining cells in the bulky region, for instance, or in the region where after the restaging, you still see tumor cells. So you will need radiotherapy and chemotherapy at the same site. But also you want to have it sequentially, because when you combine it together, then you have an enlarged toxicity, and this you really don't like. And the third mechanism is on the right. That means a real radiosensitization. That means if you give chemotherapy together with radiotherapy, it makes radiotherapy more effective. And of course, you want to treat the identical anatomical region, and you want to have an interaction between chemotherapy and radiotherapy. Normally, you want to have a kind of dose modification of radiotherapy. That means when you give chemotherapy, you need less dose of radiotherapy, which is really good for the patient because you can save them from radiotherapy-related side effects. And therefore, you need the application concurrently. That means you have to start radiotherapy and chemotherapy at the same time. I want, in the talk today, I give you some examples of this, where you can see that it really works. This is a typical radiotherapy or radiobiology assay. That means a cells surviving assay, where you treat cells in the plate with different doses of radiotherapy, as you can see here. But on the other hand, you see when you add a kind of chemotherapeutic agent like gemcitabine, when you incubate the cells with gemcitabine and you to radiate them after that, you see that the cells get more sensible for radiation. That means there are less cells still living after a certain dose of radiotherapy, for instance, 10 grays, than when you do it without gemcitabine. That means the chemotherapy has a radiosensitizing effect, which is something we like to see in vivo as well. And there are certain mechanisms who can do that. For instance, there is known that cisplatin is enhancing the DNA damage, which you can see when you do radiotherapy. So cisplatin and radiotherapy do more effectively destroy the DNA of the tumor cells. And for instance, there are other mechanisms which are really well studied that inhibit, or that they show that certain chemotherapeutic agents may inhibit DNA repairing enzymes. As you can see in this experiment down there, you see that a mouse with a sarcoma tumor has been treated first with radiation and also with fludarabine. This is a chemotherapeutic agent alone. And you see, when you do it for 4 days, you see a kind of growth retardation, and then the tumor starts growing again. This happens or if you give radiotherapy. But when you give it both, before radiotherapy, you see, this is on the right side of the curve, that the tumor is going to shrink down for a couple of days. So chemotherapy and radiotherapy may have a kind of additional effect, and so there must be an interaction between them. So, and then the tumor starts again. So you see this experiment, you can see that chemotherapy and radiotherapy act together and enhancing effect. My first clinical topic will be head and neck cancer. There you can see that this theoretical hypothesis I just mentioned is really clinical working. When you think of head and neck cancer, there are two modalities of curing the patients. The first is, of course, the surgery. Surgery, more or less, is used for less advanced tumors. That means which have less, they are lesser in size and they have not so many lymph nodes. And on the other hand, when a patient is not operable, then he gets radiotherapy and chemotherapy. This has been done for a very long time, and quite a few studies have been created with that. And what I show you here is a meta-analysis which has just recently updated. And this meta-analysis compares a lot of different trials. On the right-hand side, you see the trials which use radiotherapy and chemotherapy together for treating head and neck cancer patients. And on the left-hand side, you see for the patients who have been, or the trials who have been combined, radiotherapy and chemotherapy, but not concurrently. They are using chemotherapy first as an induction and then radiotherapy. And what you see here, the difference between the studies is that you see a survival benefit when you combine chemotherapy and radiotherapy, but only if you give it concurrently. That means at the same time. This is on the right-hand side. You see a survival benefit of quite a few patients. You see more than 5,000 patients have been in the study, and you see a constant survival benefit of the patients of about 8 to 10% when you give radiotherapy and chemotherapy together. And this is not the case when you give chemo as an induction. You see there is no survival benefit at all. So you see, when you do radiotherapy and chemotherapy together, they have a kind of enhancing efficiency. The third investigation the group did was to look if adjuvant chemotherapy does change the prognosis of the patient. And according to the things I've told you before, it does not work. So when you give chemotherapy after radiotherapy, it has no prognostic effect. So when you combine chemotherapy and radiotherapy, you have to do it concurrently. Otherwise, there is no prognostic benefit for the patient. There has been a big German trial who was actually investigating if chemotherapy is able, if you give chemotherapy concurrently to radiotherapy, if the chemotherapy is able to reduce the radiotherapy dose needed. This was a big trial in Germany, which took place a couple of years ago. And you see in the arm named HEART, that means hyperfractionated accelerated radiotherapy, you give twice a day up to 77 gray to the patients. So this is quite a lot. And the other arm, the investigational arm, was combined with chemotherapy. And you see here that the dose given to the patient is less, only 70 gray. That means if you have, the hypothesis was, if you give chemotherapy, you can save those and cure the patient better. And here you see the results. The results were positive. You have a better overall survival for the patients when you give them chemo and less radiotherapy dose. And you have a better local regional control. What the group established was that the acute side effects were a bit more prominent than when you give radiotherapy alone, but there haven't been any late side effects more enlarged with chemotherapy and radiotherapy than in the radiotherapy alone arm. So the treatment was approved to be safe and also efficient. That's the way we treat head and neck cancer in Germany still. We don't use anymore the twice daily radiotherapy because this has been proven that it's not more efficient when you give it once daily together with chemotherapy, and it's even more appropriate for the patient because he does not need to come twice a day to your department. This also can be shown in the post-operative setting. That means when you operate a head and neck cancer, and because it's more advanced, you give radiotherapy after that. In certain cases where the patient have risk factors, like many enlarged lymph nodes, which has been proven by a neck dissection or biopsy, or when the tumor was bigger, when the tumor was in large size T3 or T4, then the patient gets radiotherapy. And this was a big European trial. See that if you combine that with chemotherapy additionally, concurrently to radiotherapy, you will have a better survival, as you see here, and you will have a better local regional control. That means less regional relapse. So when you have an operated patient after surgery with a head and neck cancer, he has risk factors, he has been marginally resected, and he has lymph nodes, then you combine it together with chemotherapy, you have a better prognosis for the patient. So you see, when you combine it concurrently, you can have a higher efficiency of radiotherapy. This was the trial I mentioned. We can go briefly through. There was a randomized trial that you combine radiotherapy with combined modality treatment, 66 grays, and you see that the late side effects were not very much different from the radiotherapy only arm. So the treatment is safe. Now we switch to lung cancer. When we treat lung cancer, then you also have two options. And you know, there is a surgical option for the advanced patients. There is a radio chemotherapy option for the advanced patients. And as usual in the oncology decision-making, you always have to balance between your efficiency and your treatment-related morbidity and mortality. And this especially is important when you treat lung cancer, because when you treat lungs, the lung is a very radiosensitive organ and which is very easy to damage. There has also been a quite large meta-analysis comparing concurrent chemoradiotherapy versus radiotherapy alone for patients with advanced lung cancer. And you see the trials are still a bit old, but they show one basic result that combined treatment has a survival effect. So the hazard ratio is very in favor for the combined modality treatment. And it marks, or this study marks a standard of care for muted, so can you hear me? Okay. On the other hand, okay. On the other hand, you see the side effects. A typical side effect when you treat the lung cancer is an esophagitis, because when you treat the mediastinum, you get the radiotherapy-related esophagitis. But when you combine it with chemotherapy, it's more severe. But on the other hand, your pulmonary fibrosis is not very enlarged when you combine these two treatments. So it seems to be safe. Delayed esophagitis, that means esophagitis problems after 90 days, are not different in these trials. Of course, you have more anemia and neutropenia when you combine chemotherapy and radiotherapy. This is normal, but it recovers. And as I know, as I've shown, when you combine concurrent versus sequential chemoradiotherapy, it's still also in the lung cancer, you can see that you have to do it concurrently, that it's not a survival benefit when you give it sequentially. It means it has to go. So in our department, it's like that the patient tells us when the first day of radiotherapy is, and the day of chemotherapy, radiotherapy. Different topic, different site. Esophageal carcinoma. There are two therapeutic options, as usual. There you have surgery, but to enhance the efficiency of surgery, we use a neoadjuvant chemoradiotherapy to make the work more easy for the surgeon. On the other hand, inoperable patients get definitive radiochemotherapy. First, to the neoadjuvant setting, there's a combination of chemotherapy and radiotherapy as well. And what we do now is seen in this trial. This trial was switching a chemoradiation before surgery, so that the patient gets roughly 5 weeks of radiotherapy and concurrent paclitaxel and carboplatin, which is quite easy to bear for the patient. It's not very toxic. And in this trial, this is a Dutch trial, you can see that this therapy is effective. It's effective for the prognosis for the patient. So if the patient gets chemo radiation before surgery, the survival is better. And the survival is better for as well adenocarcinoma or squamous cell carcinoma. So for both entities, there is a survival benefit. The side effects of this trial have been quite low. So that is always the problem if chemoradiation enlarges the toxicity of the operation. And you can see here that it does not really. An experienced surgeon can cope with all that. And the additional toxicity of chemotherapy was bearable as well. when you think of inoperable cases of esophageal cancer, there is also a quite big role of chemotherapy and radiotherapy. And the trial actually, which discovered all that, is quite old. It comes from 1992 and was combining radiotherapy with at a higher dose, 64 grays, with a chemoradiotherapy of only 50 grays and cisplatin. And what you see here is that the combined modality treatment is better than radiotherapy alone, although radiotherapy was given with a higher dose. So this trial will really set the standard for treatment of esophageal cancer with radiochemotherapy, and it still is. And cisplatin and 5-FU are still used. On the other hand, you can see that also the local recurrence in the combined modality arm is less frequent, and the patient is at a lesser instant going to metastasize in the follow-up. Now we have two chemotherapy options. As I have said, there is cisplatin and 5-FU, and there is carboplatin and paclitaxel, which is, in my experience, much better tolerated from the patients. And there has been a study comparing that retrospectively, and you see that there is not very much difference. So according to this trial, it does not really matter if you give cisplatin, 5-FU, or carboplatin paclitaxel. That we do if we have patients which have comorbidities and they cannot stand the cisplatin because of renal toxicity. We switch to the other regimen. There is always the question if you need a surgery for treatment of esophageal cancer. And the answer is not really clear. As you see in this trial, this is a French trial which has been conducted several years ago. The patient you see, they have got chemoradiation, then they got randomized if they have responded to treatment. They got randomization to surgery or further chemoradiation. And what the trial group was finding is that the survival of surgery arm and chemoradiation arm was not different. So obviously the surgery is not much better than chemoradiation, but there are some differences in the trials, which you can see here. The patient which gets surgery is longer in hospital, that's normal, but has a higher post-operative mortality. But on the other hand, the local control for the surgery patient is better. So you have more interventions for this dysphagia after the procedure in the chemoradiation arm, and the local recurrence is more frequent. So still there is debate whether you need surgery for esophageal cancer patients, but when you look at the regional control, it's better to have surgery for the patients. Now I move on to the rectal cancer. Rectal cancer is also a field for using radiochemotherapy before the operation. And this comes from a trial which is actually a German trial, where they compared chemoradiation before or after surgery. This is especially important because the patient who gets surgery first and radiochemotherapy after that is not so well. The compliance of this treatment is not so good. So it's better to have radiochemotherapy before the operation. And the aim for this trial was to show that the local recurrence rate is less and the patient has a higher probability of getting a sphincter preserving surgery. And you see that the local recurrence rate in the preoperatively treated patients is better than in the surgery first patients. So local recurrence can be prevented by chemoradiation. On the other hand, the overall survival was not different in this arm, and also the probability of getting distant metastasis did not differ between these two arms. That's normal. But still, this is the standard of care in Germany when you have a more advanced rectal cancer with T3 stage or N+ stage. In the lower, in the middle, or also in the upper region of the rectum, they get chemoradiation before treatment of surgery. There have been efforts to escalate the systemic treatment. As you can see here, this is a trial with a kind of intensified chemotherapy before the chemoradiation to make the tumor cells disappear. And there had been a surrogate parameter to see if it works or not. This is the amount of pathological tumor regression with the amount of complete pathological tumor regression. And you see here that in this phase 2 trial, the group B, that means when you have the chemoradiation and then you have a chemotherapy after that, and then you do the operation, you have almost 30% of the tumor has already disappeared. So the local recurrence rate maybe is better as well, but you don't know yet because the trial is not yet ripe enough. Next topic will be cancer of the anus. As you can see here, a surgery is not a good point when you want to have a sphincter preserving surgery. This is only rarely possible in anal carcinoma. That's why anal carcinoma is a domain of chemoradiation. And I'll show you the trial which has established that. This trial is also reasonably old. It's from 1997 and was comparing randomizedly radiotherapy with a split in between and the combination of radiotherapy and 5-FU and mitomycin C. And you see here that the combination of both enhances the prognosis of the patient when you see the local regional control and the colonostomy-free survival. So the patient has a higher cure chance and also he has a higher chance of cure and he has a higher chance of survival. There have been trials to comparing different chemotherapeutic regimens, as you can see here. This is a trial comparing 5-FU mitomycin C, which actually still is used, with 5-FU and cisplatin. And this was an American trial, and astonishingly, there has been an overall survival difference, but in favor for the old 5-FU mitomycin C. So this is why cisplatin is not to be used in carcinoma, and we still use 5-FU and mitomycin C together with chemotherapy in advanced anal carcinoma. You see here that also for the colonoscopy-free survival, there has been less efficiency for the cisplatin arm, and also the distant failure rates for cisplatin have been higher. My last topic will be the cancer of the uterine cervix. There are two mainstays of treatment. As you know, you can do surgery for the less advanced tumors, but the more advanced tumors are for radiotherapy and chemotherapy, because this is still the main goal of treating cervical cancer is to offer the patient only one modality of treatment. That means either surgery or current chemoradiotherapy, because the patient will not tolerate both. So the actual guideline for treating cancer in more advanced stages is combined chemo and the randomization brings external beam radiotherapy and brachytherapy intracavitary with the same treatment and concurrent cisplatin and 5-FU. This trial is also reasonably old, but established the standards that concurrent chemoradiotherapy in this patient is having a better overall survival rate, a less local regional failure rate, and this is going through all the different stages of the tumor. That means also if you have less advanced stages, still the combined modality treatment will save life for the patient and will enhance the survival rate of the patient. Another result of the trial was that the toxicity was not very much enlarged when you think of chemotherapy-related toxicity, but it was a reasonable amount of radiotherapy toxicity because the dose you give to the cervix is quite high. But this is still the case and is radiotherapeutic associated toxicity. So these have been my examples for you to describe the very narrow relationship between chemotherapy and radiotherapy and how it's used in the clinical practice in Germany. I hope I could show you some results and the reason why we do things like this. And I thank you very much for your attention, and I'm ready for questions.
Thank you so much, sir, for your very informative presentation. I would like to pick up a question asked by Dr. Arunangshu Dash. The first question is there any evidence for concurrent immunotherapy and radiotherapy?
That is a good question. there is evidence, but much less. And we normally don't have so many advanced trials for that, but it's used. And for instance, there is a growing role of immunotherapy and combining it with radiotherapy. For instance, when you treat metastasis, there is a so-called abscopal effect. I don't know if you have heard about that. That means when you treat with radiotherapy a metastasis, then you get a kind of antigen liberation, and this provokes an immune reaction, and this immune reaction may destroy or may help the immunotherapy to work at other parts of the body. Okay, you can say this is quite rare, but still it works. And there are ongoing trials combining immunotherapy with radiotherapy, for instance, in head and neck cancer, but also in gastrointestinal carcinomas and in lung cancer. So far, there have not been real ripe results for that.
Okay, thank you, sir. I would like to move over to our next question. Is there any evidence comparing radiotherapy only versus chemotherapy only for lung cancer?
There is evidence, as I've shown you, the evidence is there for giving it concurrently. And so the aim is to give chemotherapy and radiotherapy together and not to give it sequentially, as I've shown you. Was it the question? Am I right, or did I understand something wrong?
Sir, the question was, is there any evidence comparing radiotherapy only versus chemotherapy only for lung cancer?
There's no evidence as far as I know.
Okay, okay, sir. The next question is from Dr. Shravan Chinnikati. Is abscopal effect and immunotherapy similar? Is abscopal effect and immunotherapy similar?
That means if you have an abscopal effect, means that you have a treatment effect when you do a local treatment apart from the site where you treat it. So an abscopal effect has been measured together with immunotherapy in cancer patients when you treat them, for instance, with radiotherapy, but it's rare. I think, in my experience, it's the case in 5% of the patients.
Okay, sir. Continuing with this question, is there abscopal effect occurs only with radiation or with chemotherapy also?
The most of the studies have been with radiotherapy because radiotherapy is able to do an antigen boost to the immune system. And so there have been less data about inducing an abscopal effect with chemotherapy, not as far as I know.
Okay, thank you, sir. The last question I will pick up, that is is there any benefit to give induction chemotherapy in case of head and neck cancer and give radiotherapy after that?
I know that it's quite often the case in Bangladesh because the patient is not able to reach a radiotherapy facility soon enough. But when you see the data, you see that when you give chemotherapy and radiotherapy not at the same time, it's not as effective. But as I realized in Bangladesh, it's often used as a kind of bridging therapy. That means before the patient gets access to the radiotherapy department, and therefore you can use it because it's very effective and it gets tumor shrinkage. But you should then combine radiotherapy and chemotherapy when the patient is coming to your radiotherapy department to start the definitive treatment. So you should not think that because the patient got chemotherapy before start of radiotherapy, you can omit the chemotherapy. That is wrong. You have to combine it also.
Yes, sir. Actually, Dr. Shravan Chinikati sir also asked, is there any abscopal effect with ablation with RFA?
That's a difficult question. I don't know, actually, because I don't remember any trials of that. I'm sorry, I cannot tell you. I can imagine that it's not so prominent because when you do an RFA, you simply boil the tumor and you don't have any antigen left because you only produce a necrosis. But I cannot tell really because I don't have any data in mind.
Okay, thank you so much, sir. We have some more questions, but we will take it for later and give it to our questioners who will ask the question. Now, I would like to move forward to our next presenter, Dr. Raihan Rabbani, to present his today's topic. His today's presentations is on chemoport installation, Bangladesh perspective.
Thank you. Thank you, Ms. Nashita. A very good evening to all the audiences. I am an intensivist actually, and I work in general ICU. And I'm also.
Hello.
Hello.
Hello. Should I continue?
Yes, sir. Please continue.
Okay. Can you see my slides? Okay, so I work in Bangladesh in a tertiary care private hospital in Dhaka, the capital of Bangladesh. I do the chemo ports in my hospital, and I am very keen to do it and try to help the patients. So Bangladesh, you all know, it's a small country just bounded by India in one side. The other side we have Myanmar, and we have the Bay of Bengal in our downside. So it's only 56,000 square miles, which is 92nd if you compare to the size. But we have like 164 million people, which is like 8th biggest in the world. And if you look at the earning, our GDP is around 6,000 US dollar per capita. It's 1/30th in the whole world. So we can imagine where we can stand in terms of treatment, especially the expensive cancer treatments. So this is the picture of cancer in Bangladesh, this data. So our total population, it's like 164 million. The number of new cancer cases is about 1.5 million every year. Number of deaths is like 1 million. And number of prevalent cases is like 2.7. So the most common cancers, if you consider, in male and female, it of course differs. In males, it's more the esophageal cancer, then the lung cancer, followed by deep and wall cavity cancer. Stomach and hypopharynx cancer is also prevalent. In female, we have breast cancers as one of the more common cancers. And many of these cancers also require chemotherapy, radiation therapy, and all those things. So this is my hospital, it's a square hospital, and you can see the main building, and we have our radiotherapy unit in the basement of this building, and we have our chemotherapy center in the other building from where the picture was taken, and it's connected by this bridge over a main road of Dhaka city. So we'll be talking about vascular accesses and chemoports. So the chemoports, what are these, and why we use it, and why it's not popular in Bangladesh and the subcontinent. We'll talk about that. So in Bangladesh, the chemoports, we have for chemotherapy access, mostly we use peripheral IV cannula. In all the centers, I think more than 95% of the chemotherapy is given by the peripheral IV cannula, which is not ideal in many of the chemotherapy agents. PICC line, it's not that much used in Bangladesh, and chemoports, it's also very rarely used. Only in few centers in Dhaka, it's performed. So why this role is important about chemo ports and all those things, the vascular accesses. So you can see some of the examples, what happens if the chemotherapy gets extravasated. Even in cases where the chemotherapy is not extravasated, there is phlebitis, and many times we see sloughing, cellulitis, and other complications. So appropriate access of for chemotherapy is very important. I'm sure the oncologist, you are much more familiar than me regarding the side effects of chemotherapy. So if we give chemotherapy via central venous access, the complication rates are much less, because the chemotherapy gets diluted in the very high blood flow of the central veins, and definitely it creates much more easier access for the patients and also for the oncologists and the nurses. So what are the central venous access devices? So we can use non-tunneled venous central access. So we all know about central venous catheters. So those are central lines. We know about hemodialysis catheters, and we also know about peripherally inserted central venous catheters, also known as PICC lines. So these are very convenient. We can use those, but the problem is the infection rate from the infection rate is very great from these non-tunneled venous central catheters. We can also use tunneled venous access catheters. We call it pharmacats, and both of these tunneled and non-tunneled venous catheters, some of the part of the catheters dangling outside the body. So that creates some problem for the patients. So there comes the role of the chemoports or mediports. So these are completely implantable central venous access. You cannot see anything dangling outside of the body, and there is less chance of infection. And that's why the role of these chemoports are very good. So you can see the picture on the right-hand side. This is a chemoport here. So you can see the port. The port is this one. It comes in many sizes, many shapes, and in many materials. And we also have this catheter that goes through a tunnel and goes into a central vein, a bigger vein. And this port that gets implanted under the skin, and you have to palpate this septum and access the port and put in the medication through this septum in this port, and it will go through this catheter to the central vein. So this port can be implanted in many sites, and it can be done through the veins like subclavian vein, internal jugular vein, axillary vein, and brachial veins. You can implant it in the chest, you can implant it in the hands, and also it can be implanted in many other sites depending on the patient's body habitus and other criteria. It can be done on the right side, left side, wherever we can feel convenient. So these are the pictures of one kind of chemoport. So this is the actual port. So what we do, we put in a needle here, and there is hollow inside, and we put in the medication there, and it goes through this catheter to the vein. And we have to think about this material, whether it's stainless steel, whether it's titanium, whether it's plastic, because that makes a lot of difference when you're going to do an MRI, when you want to do a CT scan, those kind of things. About the pressure that can be tolerated by these chemo port and the catheters, that's also important, because when we'll be injecting some contrast media, especially during imaging, the tolerance of this catheter and the tolerance of the port, that becomes important, because most of the contrast medias are injected through a automated injector, and it creates a lot of pressure. So we have to know whether the port that I'm implanting is good to use with a automated injector or not. So, and we have like 2-port venous catheters. We have 1-port and different sizes. So this is a typical installation set of a chemo port. So I'll be talking about how to implant a chemo port in short, and we have to know about some of these things. So what we have here, we have a needle, so to access the veins. You have the tunneler. So this stick-like metal stick is a tunneler. So you make a tunnel from the port pocket to the venous site. You also have these spatial kind of sheath that can be splitted after introducing the venous catheter. And this sheath is also, there's inserted is a dilator that will be used to dilate the vein. You have this guide wire, and you can see the port here on the right side, and you can see the catheter in the middle, and there's a needle, spatial needle that we can use with the port. So how it looks after we insert the port. So you can see here on this side, there is a port here implanted at the chest, on the right side of the chest, and you can see the catheter that's running up beneath the skin, and here crossing the clavicle and going possibly in the internal jugular vein. On the left hand side, you can see the another picture that there is a port on the left side, and that catheter also goes crossing the clavicle and possibly in the left internal jugular vein. So most of the time we prefer the right side, because the internal jugular vein that goes directly into the right atrium, and it's easier for us to place the catheter tip in the right atrium if we place on the right internal jugular vein. But there are certain issues that you may have to use the left side also, especially if we plan to use radiotherapy on the right side. In that case, we would prefer to get the port implanted on the left side of the patient. So in the middle picture, you can see the port that the patient has port on the right chest, and the catheter, it's going and getting into the internal jugular vein and goes all the way to the superior vena cava, where it ends in the just before the right atrium. So you can see a cross section of the port. So the blue part is the septum. So it's mostly made of silicon, and the fibers, they are usually splits away when the needle is introduced, and again it gets compacted and seals so that nothing leaks out of this cavity. Any medication, any saline that goes through this cavity to the catheter, and in turn it will go to the vein. So we'll be starting the procedure, that what we will be doing in the procedure. So after draping and proper disinfection, we will infiltrate the area, the internal jugular vein area, with the local anesthetics. So we are planning for the vascular access first, then we'll be using the making the port pocket. So when we are doing the vascular access, it's preferable if we use the ultrasonic guidance. So the complication rates will be much lower, and we can do it for sure. So you can see the ultrasonic probe held in one hand, and on the other hand, we are introducing a needle. And you can see on the ultrasound picture, you can see the needle here. It's going into the internal jugular vein. So once we make sure that the needle is in the internal jugular vein, we can pass a guide wire through the needle and pull out the needle and left the guide wire inside the vein. So you can see the guide wire, it's going inside the within the vein. And if we have at the advent of fluoroscopy, then we can confirm the guide wire that it's going into the superior vena cava and in the heart. So the fluoroscopy is much better and safer, but it's not available everywhere. And me myself, I don't use fluoroscopy while doing the chemo port because of the scarcity of the fluoroscopy and the cost involved. So I do it without the fluoroscopy, and I didn't face any complication for that reason. So after that, we like to just keep the guide wire in situ in the internal jugular vein, and then we will make a mark of the pocket that where we want to keep the chemo port. So usually the pocket is just above the second rib, and you can just palpate the second rib, and you can just make the marks and incision marks here, so that the port will be lying just below here, and it will rest on the one of the ribs, most commonly the second rib. So after marking, we filtrate the area with a local anesthetic because there will be incision, and the port will be implanted here. So after infiltrating the incision area, we will also infiltrate the line between the venous access site and the port pocket. So this is the area where we will create the tunnel. So the catheter will come from the port pocket through this tunnel to the venous access site. So this tunnel is also anesthetized. So after that, we will start the incision here, and the incision, after the incision, we'll create a pocket here, depending, the size will be depending on the size of our port. And this pocket will be creating with the blunt dissection with the forceps and also with the help of fingers. So after creating the pocket, we will, you can see the port here, we'll insert the port, and we will make sure that the port can be accommodated within the pocket. So then we will be starting the tunneling part, the tunneling from the pocket to the venotomy site. So before that, the venous access site, the skin needs to be little relieved, and the area here needs to be a little more so that we can get the catheter inside here. And then we'll get the tunneling tool. One end of the tunneling tool will go through the from the upper part of the pocket to the venotomy site, and the other end of the tunneling tool will be attached to our catheter that will be inserted in the vein. So we can just push the tunneling tool. The descent is sharp, and the tunneling tool will go through the subcutaneous tissue, and we have to make sure that it comes out near the incision that we made while opening the venotomy site. So you can see the tunneling tool that's coming out here on the neck, and we'll just pull out the tunneling tool from this side so that the catheter comes out of this venotomy site. So that's the thing that we need to do. So now we are ready to introduce the catheters one side to the vein, and the other side will be connecting to our ports. So here we are preparing the vein. We are introducing the dilator along with the splittable sheath in the vein. So we can introduce the catheter through the splittable sheath. So you can see this white end here. So this is the end of the dilator. You can see the guide wire coming out from the dilator here, and the green part here, this is the end of the dilator, and you can see the blackish ash part. This is the splittable sheath. So we are introducing this in the vein with the help of the guide wire, and the guide wire is coming out of the dilator. So the dilator and the sheath is all the way in, and the guide wire is here. So after that, we'll remove the dilator, leaving the sheath inside the vein, and also we'll remove the guide wire. So you can see here that the guide wire and the dilator is coming out, and the sheath is left in that place in the vein. So after that, we'll just pull the catheter and we'll insert the catheter tip through the splittable sheath. So you can see here that we are trying to put in the catheter through the splittable sheath here. So after putting in the catheter, we will just split the sheath. You can see one side of the sheath here, and the other side is here, and we'll take out the sheath completely. So we'll be leaving the catheter inside there. So after this, we'll be just placing the catheter there, and through the fluoroscopic guidance, we'll make sure the catheter end lies inside the superior vena cava, the lower part of the superior vena cava. That's the ideal place. Within right atrium is too deep, and if it's beyond the last 2 centimeters of superior vena cava, it's too distal from the heart. So we'll make sure about that, and then we will cut the catheter near the pocket site, and after that we'll connect this end to our port. So that's the basic thing that we are doing now. So after that, so we'll be connecting the port to the catheter, and after connecting the port to the catheter, we have to lock it, and different port has different mechanism for locking it, and we have to take care that the locking is taken care of properly so that nothing leaks out here. And also we have to be very careful to avoid any kind of sharp instruments coming in contact with the catheter, so that it doesn't get leaked or anything doesn't leak out of the catheter. So after that, we'll be putting the port inside the pocket that we created before, and we will secure the port with sutures so that it doesn't get dislodged, especially if the patient is fatty, and in females where the port can get dislodged easily in the chest area, and it can be dragged by the breast tissue downwards. And if it goes too much downwards, it will also pull the catheter from the side in the superior vena cava. So we're almost done here with the chemo port, and we just have to check the chemo port before closing all the wounds that we have created and confirming the position of the catheter. So you can see in a fluoroscope or X-ray that this is the port, and you can see the catheter going all the way to the clavicle. Then it will go to the superior vena cava, and it will go into the upper part of the superior vena cava. Here in this picture, the catheter tip is identified with the right atrium, which is actually not ideal. So after that, we just have to close the wounds, and you can suture it the way you want. And you also have to close the wound in the neck area where the venotomy was performed. So that's the way that we do the chemo port. It's easy. It's little technical, but it's not a very difficult job. And anyone who is accustomed with getting a line in the central veins, it's very easy for them. So if someone is trained with the chemo port, they have experience with surgery or the basic surgeries, they can learn the procedure of civil line and they can do the port. And if someone has the skill of doing the central lines, they just can have the basic knowledge of the surgery and they can get the ports done very easily. So it's not that rocket science. So what we actually use the ports for? We can use the port for chemotherapy administration, of course, that's the main target. And we can also use the port for blood draws. For all the labs, we can use the port, and that's usually practiced in Western world, but we are not accustomed for that. And our phlebotomists, they are not well trained to access the ports. So we have some patients with ports, we are not utilizing it properly. So whenever we are drawing blood, we're accessing the peripheral veins. That's cumbersome for the patient. And also we are not using the ports properly, especially in patients with breast cancer, where we cannot access the veins mostly on one side. The other side is used repeatedly and the patient gets annoyed, and also that hurts them. So you can see the port here in the picture. So this is the septum, and you can see these beads here that you can palpate through the skin, and you can decide where to prick the skin. So we prefer to prick the skin here in the middle, and we use special kind of needle that we call Huber needles. And after introducing the needle here to the floor of the port, we can inject or we can withdraw blood from here, and the blood will directly come from a central line. And if we are withdrawing blood for blood tests, the first 5 to 10 ml blood should be discarded and not taken for tests. And then we can take the rest of the blood for lab tests. And then we can give the first 5-10 ml blood back to the patient, or we can discard that also. So after doing the ports, after a few weeks to months, it should look like this. So we have a port here, and the catheter, you can see faintly it's running through here, and here the catheter goes in the internal jugular vein. So whenever we are trying to access the port, we just clean this area properly, and we'll just palpate before that, and we will introduce a needle just in the middle of the port. And you can see here that these beads are for palpation and to decide where to prick. And this is a needle, specialized needle that goes through the skin and then through the septum. And we keep on introducing the needle till it touches the metal floor here to make sure that we don't displace the needle anywhere. So this is the needle, Bhubon needle. This is a special kind of needle. The tip actually is special. This is the Bhubon needle, and this is actually a regular needle. So what is the difference? The difference is the regular needle is kind of a pipe, and the tip is actually sharply cut and beveled. So when this needle is introduced in a septum or in a tissue, what happens is the tissue or the septum, a core of that tissue or septum can get cut and can get inside the needle, and with repeated use, some part of the septum can be very weakened, as with each prick the septum is weakened and some part of the septum is getting into the needle and getting cut. And this Huber needle, so this Huber needle is actually like a pencil tip kind of thing, and this bevel is not there, and there's an opening at the sides. So whenever we are introducing the Huber needle, the Huber needle will try to just split the fibers from the septum, and then the opening of the needle will be on the side. So the fluid will, fluid, blood, whatever will get out of the needle from the side. And whenever we are withdrawing the needle, there will not be any cord that will be cut out with the needle, and the splitted fibers of the septum will get again compacted, and the septum will not be weakened by repeated use with the Huber needles. So we have to make sure that whenever we are accessing a chemo port or a mediport, we will be using a Huber tip needle. So most of the chemo port also comes with this kind of Huber needle, and this needle goes in, and we can fix the needle with the skin here, and we can use these extensions for infusing or transfusing, and we can keep this needle for days together so that the patient doesn't have to be get pricked repeatedly in long cycle chemotherapies. So usually it's kept in there for, if needed, for 72 hours, and after that we can change it. So while accessing the port, we just have to, you can see the port is here in this patient, the cut mark of the port pocket is here. We just have to clean the area, and then we can access the port with a Huber needle, and then cover it with a transparent dressing so that we can inspect the prick site every few hours to every days, and use it whenever needed. So why the chemo port is less used in Bangladesh? So for me, we don't have a formal study, but the prime cause that we are not aware about the chemo port. So the awareness is definitely less amongst the patients, and also the awareness is not that much amongst us, the physicians. So we need to get familiar with the chemo port use. And as you see that this is a very easy procedure to do. And once you do it, you can leave it for long. And this chemo port is also unfamiliar to doctors and caregivers like nurses. So we are afraid to use it. That's why we don't advocate our patients to use it. The expenses is also a concern, but I think that the concern is not that much, because many patients who have irritant chemotherapy through the peripheral vein, they end up like paying much more than the cost of the chemo port if they have a complication. And the expenses when we are doing a chemo port, it comes around, if I say that in Bangladeshi taka, it will be around 50,000 taka, including the procedure and also the cost of the chemo port and all the expenses covered. So the 50,000 Bangladeshi taka translates into around $600, I think. The protocols, I'm in favor of making protocols for a specific type of cancer and chemotherapies and specific type of patients. So those patients needs to get a chemo port done whenever they're getting the first dose of chemotherapy. So for popularizing the central venous access for chemotherapy, we have to create awareness among the oncologists, among the oncosurgeons, and also the patients. So we have to plan the port placement along with the initial treatment plans. So those patients who will be getting toxic chemos, toxic for the peripheral veins, so those patients should get the plan of placement of a chemo port while they're having the chemotherapy plan from an oncologist. The placement may be done at the time of initial cancer surgery, especially if the surgery is clean, like a uncomplicated breast cancer. So the surgeon can do the surgery and also put in the chemo port at the same time. And we have to train up the phlebotomists and the nursing staff to make sure they can use the chemotherapy ports properly and confidently. And we have to also make vascular access team or IP teams for hospitals. This is a very common practice in the West. They have access teams and IV teams consisting of nurses, paramedics, and in some cases physicians, but this practice is not that popular in Bangladesh. So if we do that, the vascular access would be much easier for our patients. Thank you. Thank you for listening.
Hello, Nashita, are you there? Hello. Thank you, Dr. Raihan, for your excellent talk. Maybe Nashita has some problems with internet connections. We have received some questions. So can you hear me? Everyone, I think everyone can hear me.
Yeah, we can hear.
Yeah. So there is one question from Dr. Urnangshu Das. After how many days of interval after installation, we can use the chemo pot for giving chemotherapy? Can we use it immediately after installation?
Yes, we can use it just after installation. There is no technical difficulty, but the difficulty or problem would be with the healing of the wound. So we are giving chemotherapy and there is an active wound in the port pocket site and in the neck. Although the wound is very small, but the healing can be impaired and the chance of getting an infection is a little more. So I personally prefer to give the chemotherapy at least 1 week after installing the chemo port. So if we plan ahead, we can do it. And if the chemotherapy is very urgent, in that case, we can take certain risks and we can also give the chemotherapy just after installation. Thank you.
Okay, thank you, Dr. Raihan. The next question is, what about the chance of extravasation through chemo port and how many times we prick the needle through port?
If we are using the chemo port properly, the chance of extravasation is very less. We just have to be careful that we are palpating the port right. We are introducing the needle and make sure there is a blood coming back when we are suctioning the port. So if there is blood coming through the hub, then we are sure that we are in the port and the blood is coming from the central line. So in that case, the extravasation is very less likely if the needle doesn't get displaced. So we have to make sure the needle is secured properly, and then we can infuse the chemotherapy there. And while implanting, we have to make sure that the catheter is not damaged. And while accessing the port, if we prick inadvertently in the wrong side, and if we injure the catheter, in that case, there can be extravasation, but that's a rare occurrence. And if we are using the chemo port under very high pressure, like with a very small syringe, or as I mentioned before, with the automated injectors, then the catheter has a chance to get damaged if those are not prepared for to stand those pressure. In that case, extravasation can happen, but it's very less likely.
Okay. The next one is there are many good number of peripheral veins with well-trained phlebotomists. So do you still indicate prefer chemo port in that case?
That depends on the chemotherapy that we will be giving to that particular patients. So in some patients, like the FOLFOX, using FOLFOX for a patient, that's very irritant to the peripheral veins. And doesn't matter how good the peripheral vein is, if you keep on infusing those kind of chemotherapy, it will get thrombosed and you will not be able to use those chemotherapy therapeutic agents through those veins after a certain time. So in those patients, I would prefer chemo port definitely. And it doesn't matter whether the phlebotomist is trained or not, those chemotherapy will damage the peripheral veins.
Okay, how much it cost in our country?
The cost, as I mentioned, that the cost depends on the center and also on the performing doctor who is doing it. So usually the price of the port varies somewhere between 25 to 35,000 Bangladeshi taka, and the rest will be the cost of the procedure. And also you need some medication, suture material, and you have to, maybe you have to use ultrasound machine, the fluoroscope, and you have to do an x-ray. So all those things included. In my center, the cost is less than 50,000, and the patient doesn't have to stay in the hospital. It's a daycare procedure. They can come and leave within 3 to 4 hours.
Okay. What about in carcinoma breast cancer patient? Which side do you prefer chemo port and why?
Okay, so that depends on the carcinoma breast, on which side the carcinoma is. So if the carcinoma is on the right side, in general, as I told that we prefer to install the chemo port on the right side of the chest because the internal jugular vein is easily accessible there and it straight goes to the heart. So the chances of the catheter going to the other side is very less. So right side is preferable in any case, but if someone has a right breast carcinoma and the oncologist is planning for possible radiotherapy on the right side, we prefer not to use the right side, especially if the port is made of metal, titanium, or if it's made of stainless steel. So in that case, we will do it on the left side.
Okay, thank you. So how often does it need to be flushed with heparin solution to prevent thrombosis?
The catheters are like, we have several types of catheter now. So there's a open-ended catheter, and there is another new catheter we call it's a catheter with a Grossong valve at the top. So in the tip, there is a valve that prevents reflux of the blood. So in that case, we don't have to flush that port very often. So in most of the cases, the port can be flushed somewhere between 4 to 6 weeks. And flushing with normal saline, if the patient has a Grossong valve, is enough. And in open-ended catheters, flushing with a heparin solution may be better than flushing with a normal saline.
Okay, thank you. So there are so many questions because after your lecture, so many people would like to have many questions about chemo port. So one thing is, what do you recommend in case we are suspecting chemo port infection? Antibiotic, any antibiotic of your choice, and would you recommend removing it upfront?
Removing the infection can be like there can be different types of infection. One we call like pocket infection. So the infection is around the port pocket. So in that case, if it is just a cellulitis, we can the cefuroxime, or we can use the linezolid type of antibiotic and see. So before administering antibiotic, if we can have some pus or secretion from there, in that case, we will be able to get the organism and sensitivity, then we can tailor the antibiotic therapy as per the culture results. If the infection is within the tunnel, so we can use antibiotic. And if there is a really port-associated catheter infection, in that case, if it is due to gram-negative bacteria, in most of the cases, we have to remove the port. But if it is from gram-positive bacteria, maybe we can try administering antibiotic and then see if the infection goes away, and then we can keep the port. But in most of the cases, we may have to remove the port if there's infection.
Okay, so maybe there are two more questions. What about if we are installing the chemo port which is not functional? Can we again advise for repeat chemo port installation?
Yeah, of course. So the thing is, why it is not functional, we have to find it out. So if the chemo port is not functional because of a thrombosed catheter that we didn't flush it properly, or even if it is after flushing the catheter is blocked, we can use thrombolytic drugs and see if the block is opened. Sometimes the catheter gets kinked, and if you just manipulate through the skin, the non-functional port again becomes functional. So we have to look into those things, that why the port became non-functional. And if we have to remove the port for some reason like infection or that kind of thing, of course we can reimplant another port. And in case of venous thrombosis in the internal jugular vein, only in those cases we like to avoid port implantation because the catheter may precipitate further thrombosis.
We have ended the question. Now I am giving to Nashita to continue. And thanks Dr. Raihan and Dr. Semrau to have a nice and excellent presentations.
Thank you.
Thanks.
Thank you all.
Thank you.
Thank you, madam. Thank you so much, Ryan sir, for your wonderful presentation. I hope that everyone will be benefited from your presentation. We are now at the end of the program. We appreciate everyone taking your valuable time of your busy schedule. Goodbye and see you tomorrow in our second day's program. Thank you.
Hello. I'm requesting everyone kindly turn on your camera. Can you hear
Hello?
me?
Yes, please.
I'm requesting everyone kindly turn on your camera.
Oh, okay. Hey, please, I'm requesting everyone to turn on your camera, please. We would like to take a snapshot. Those who are online, please open your camera. Hello?
Okay, I think we can close the event.